Thank you very much for inviting me to speak today. Today I'm going to talk about robot-assisted spine surgery and how that can help relieve back pain. I trained at Harvard Medical School, followed by a neurosurgical residency at Duke University Medical Center, and then a specialty orthopedic spine fellowship at Cedars-Sinai in Los Angeles. And I've been practicing for just under 20 years here in Boulder at Boulder Neurosurgical and Spine Associates. I've given a couple hundred presentations. I've published a little over 100 papers, peer-reviewed journals, and I've been the principal investigator for quite a number of FDA clinical trials, and we have ongoing clinical trials through the practice, usually about a half a dozen or so at a time, trying to advance the field and looking for new and better techniques in the treatment of cranial and spinal disorders. So let's talk about back pain for a second. More than 65 million Americans suffer from low back pain each year. Up to 80% of adults experience low back pain at some point during their lives. Most episodes resolve spontaneously, but it is the second most common reason for visits to your physician. Most back pain is chronic, about 60%, consisting of deep, dull, aching pain lasting for more than 3 months, what we usually consider chronic. About 30% is acute, a sudden, intense pain, and then about 10% or so is somewhere in between that, what we call subacute. There are a number of different causes of back pain. This just shows some basic anatomy. Let's see, I didn't try this laser pointer. The vertebrae, the intervertebral discs, the facet joints, you can see over here, this angle, I can't really, maybe I'll walk over here, point at these things. So the discs, you can have herniated discs into the foramen. You can have pain from the facet joints, from the nerves themselves. You can have masses in the epidural space, quite a number of different things. Different structures producing pain include irritated nerves. 90% of low back pain involves some sort of pinched nerve or irritation causing tensing up of the muscles. You can have inflamed joints. Those are called the facet joints, which are in the back of the spine that move along with the front, which is the disc. You can have herniated discs, which can be present in up to a third of adults over the age of 20. As you get older, the discs degenerate more and more, and it's more common to have disc herniations. You can also have bony issues, such as tumor or fractures from trauma, or ligamentous injuries, such as tears or strains. This shows a number of different spinal conditions: facet joint osteoarthritis, spinal stenosis, degenerative disc disease, which essentially all of us will get at some point in our life if we get old enough, spondylolisthesis, which involves a slipping of the bones on the discs, disc herniations. Osteoporosis can cause problems, which is thinning of the bones. Piriformis syndrome is a common cause of complaints. Tumors, infections, the list can go on and on, but those are the major ones. Let's see, what happened here? Let me back up. I think I might have hit it twice. Okay, the majority of back pain is caused by muscle strains. It's very common for just somebody to be out gardening or pulling weeds or moving rocks or shoveling snow, and they end up with terrible back pain. They wake up the next day and they can't move, and that's a big cause of that is just strains in the muscles, and that usually heals on its own with conservative treatment. Non-surgical physical therapy can help, anti-inflammatories, ice for the first 24 hours, then heat, maybe even 48 hours for ice. Excuse me. Radicular pain or sciatica can also be an underlying cause of back pain, which radiates down into the legs. You can have burning or shooting pain starting in the low back or buttocks, radiating down into the front or the back of the leg. You can also have radiating numbness, also associated with weakness or what we call paresthesias, which are tingling. You can have unilateral symptoms. You can also have bilateral, depending on the situation, how big the disc herniation is, or the tumor, or other issues. This is just a schematic of piriformis syndrome. The piriformis muscle runs from the sacrum to the femur, and the sciatic nerve comes right under that. So the muscle can become very tight after certain types of activities or a muscle pull or something like that. You can also get issues from prolonged sitting, car accidents, trauma, falls, variety of different things that can cause pinching of that sciatic nerve and radicular symptoms. Spinal stenosis is another common cause of radicular symptoms. It can be a result of normal progression of aging, but most people do not develop spinal stenosis symptoms, even though all of us, as we get older, will develop some degree of spinal stenosis. Most people do not require surgery. The physical exam is often normal. Weakness and numbness are not typical, but you can get that if it gets bad enough. If the spinal stenosis gets severe enough, you can actually have bowel and bladder changes in addition to weakness and numbness. But most common thing is pain. This is a classic presentation here, a diagram of somebody with spinal stenosis, an elderly person who has back pain, especially when they stand up straight and erect, because the ligaments kind of buckle and contribute to even more stenosis and pinching of those nerves. And when you lean forward, I almost always ask if I think somebody has spinal stenosis. They come in, they don't have an MRI. They come in and they're complaining of typical spinal stenosis symptoms. I ask them, do you ever go shopping? Oh yeah, I go shopping. Do you get a shopping cart and lean on the shopping cart? Yeah, that feels a lot better. I can walk a lot further if I lean on that shopping cart. So that's classic presentation for spinal stenosis. Disc herniations can be caused from just age, where the disc degenerates and becomes less elastic, or an acute injury can also cause a herniated disc. As you can see here, there's a healthy disc on the left, and then on the right you have a disc that's popped out, and it's pinching that nerve as it exits what we call the foramen, the little hole in the bone that the nerve goes through. If that disc pops out and pinches that nerve, then you end up with usually radicular pain or back pain, and severe compression, or especially severe prolonged compression, can lead to permanent nerve damage. This shows a real MRI of a very large disc herniation. You can see that down there. I'm not sure you can see that laser pointer very well. Maybe if I use the arrow. Can you see that arrow up there? Here's the disc herniation here, and then it's almost complete effacement of the spinal canal, causing severe stenosis. There's a lot of treatment options. My friends who are physical therapists, I send a lot of people to physical therapy, and I kind of joke about them putting them on the rack. Here, as you can see, back in the old days, people were stretched out on the rack oftentimes. That actually has some validity to it. We do have tilt tables and things that stretch your back out that can definitely help. Other things like anti-inflammatories and different types of stretching, nerve glide techniques. And then if you fail that, then there's the option of surgery. There's different types of surgery. The open traditional surgery was typically performed over the past 40, 50 years, and then more recently, over the past 10 or 15 or 20 years, we've done more minimally invasive surgery with smaller incisions, and that's kind of where the robot comes in, where we can do more minimally invasive surgery with more consistency. So what exactly is minimally invasive surgery? When we talk about, quote, minimally invasive surgery, that's kind of a whole basket of things. It typically involves smaller incisions, less scarring, less blood loss, shorter hospital stays, less postoperative pain because you don't do as much dissecting, less need for narcotics, and a faster return to work and daily activities. This is, kind of just a picture, a Rembrandt actually, of kind of what they used to do in the past. And this is another kind of old school surgery here where you make a big giant incision, put in a lot of screws and rods and connectors, and that causes a lot of postoperative pain and a lengthy recovery. This is more of a present operating room where we have lots of monitors and cameras and image guidance, and robotic spine surgery is one of the newest techniques. This just shows some of the pre-planning things that we do. So we can get a CT scan, we can get that intraoperatively, you can get that preoperatively, and then you can plan everything you do before surgery. So you can see these instruments going into the spine exactly where we want them. We pre-program the robot, as I'll show you in some further pictures. So why robotic spine surgery? Well, in theory anyway, we can make smaller incisions, which result in smaller scars, shorter hospitalizations, lower theoretical risks of side effects, faster overall recovery, less pain, less blood loss. We don't have to donate before surgery, quicker return to normal activity. Those are all good. What exactly can robots do? Well, this is a robot here. My wife has one of these. It can vacuum the floor without having to worry about it. So that's just one example. So the Mazor X is obviously a much more advanced robot than the vacuum cleaner. It received FDA clearance in 2018. It's made significant advances over the last 10 or 15 years it's been around. When it originally came out, it was literally like a little tin can, and it didn't do all that much, but now it's made much more advances. We can customize, excuse me, customize plans for each patient preoperatively. We can significantly reduce the need for intraoperative x-rays and radiation exposure to both the patient and the physician. It can help eliminate the error associated with free-handed screws and other instrumentation that we do. It can reduce the so-called 10% misplaced screws that have classically been involved with deformity surgery down to as low as 0.8 or 2%, and reduce the incidence of permanent nerve damage. Similarly, potential OR time reduction after the learning curve, and an overall reduction in complications. It can basically facilitate minimally invasive spine surgery. So this shows some of the things we do is this video preoperatively. We put all these things in place. We plan them preoperatively. So this shows us placing the screws where we want them before surgery, putting exactly the right angle, moving things around in all kinds of different planes, and then the robot will basically help us do that. In surgery, we do the exposure, hook the robot up, and it will do exactly what we tell it to do preoperatively. We plan for it preoperatively, and it does it intraoperatively. This is another view of just planning the screws before surgery, and this shows laying the rods in. They're all in nice sequence. Sometimes when you're freehanding things, you get screws that are kind of this way and that way, so you got to bend the rods all kinds of crazy different directions. So the robot can help with that significantly, so that you don't have so much trouble placing rods and reducing deformities in surgery. This is a video, and it has some words associated with it. I'm going to play this video, and you can listen to this.
Once the planning is complete and we know exactly where to place the instruments, The Mazor X saves the instrumentation during surgery. The Mazor X reproduces the same plan with precise stereotactic navigation by recreating the planned trajectory for the patient during surgery. The benefits of this technology to our patients.
So the benefits of this technology, there's multitude of potential benefits. It is still under development, so not everybody is a candidate for robotic spine surgery. It doesn't help everybody, but in those that it does, it can significantly improve on the accuracy of the screw placement, on the precision, on the consistency. So this shows a robot throwing a dart. You can see the dart way down there low at the 3, and it missed basically. Then the second one, boom, is right on the bullseye. So it learns, the robot learns. Then the third one, bam, bullseye again. So then after that, it's bullseye, bullseye, bullseye. So the robot can learn from its mistakes. Humans can too, but since we can pre-program this robot to do what we want to, beforehand, then it can potentially eliminate that initial mistake. This just shows some of the papers that have been published. The early robots had somewhere in the range of 5.7 to 5.9% errors. That went down to 2.3%. This went from 2014 to 2017, went down to 2.3%. And then the latest one, 2019, went down to 0.5% error, which is very, very low. So in short, the robot will not make a bad surgeon a good surgeon, but it can make a good surgeon a better surgeon and significantly help with doing a lot of things like minimally invasive spine surgery. Can help improve on those techniques and reduce errors and improve precision, accuracy, consistency. Thank you.
Thank you so much, Dr. V. We're going to take just a moment and wait for some questions to come in.
Okay.
Looks like you lost your screen there. Tap that again so in case you need to flip back.
We can go back to one of the different screen here.
Yeah. So we do have one question so far while we're waiting for others to come in. Can robotic assisted surgery help to alleviate the pain from scoliosis?
Oh, absolutely. So scoliosis is just one type of deformity. So we treat all kinds of different deformities with screws and implants and interbody cages and other different things. And what the robot does is it helps us treat those things. It helps us be more precise and more accurate and more consistent. So it can absolutely help with the pain of scoliosis. The robot isn't going to cure scoliosis per se. You can't take a robot and just go and cure scoliosis. But what it does is it helps us in the techniques that fix scoliosis. And it can definitely help with reducing pain of that disorder.
So it can repair
Yes.
scoliosis. Excellent. I see we have a visitor. That's okay. I've introduced Goose already to our attendees. So a guest here asks, and I would ask too, what is the process for getting to the point where you will have this surgery? In other words, do you first need an MRI?
Well, typically we see the patient in the clinic and assess them for, we don't usually go straight to surgery. We usually try to treat people with non-surgical techniques, such as, like I showed, physical therapy, anti-inflammatories, muscle relaxants, physical therapy, core strengthening, stretching, all those things. And then we can also go to steroid injections, other types of medications, and then if they fail all those things, then they become a candidate for surgery, and then once we determine that they are a candidate for surgery, then it's a matter of deciding who's a candidate for minimally invasive surgery versus open surgery, and whether the robot can actually help. The robot doesn't help with every single spine surgery. Some surgeries are not appropriate for that, but there are a lot that are.
Excellent. Is there an age limit for success with osteoporosis with this surgery on, say, a 65-year-old?
Well, again, the robot will help us with the accuracy and the precision of the screw placement, potentially anyway, and then that can reduce the complications associated with the surgery in somebody with osteoporosis. And so yes, it can definitely help. Again, it's not going to cure the osteoporosis like it's not going to cure scoliosis, but it's one tool that adds to our toolbox and our armamentarium to help those patients and improve on those techniques.
Does Medicare pay for this surgery, cover this surgery?
Well, yes, Medicare typically pays for these kinds of surgeries. They don't pay extra for the robot. So, the physicians don't own the robot, so we don't bill for the robot. So that's kind of a question. The hospital owns the robot, so I don't think they can bill per se for the robot, though. So Medicare will pay for the surgery. Whether we use the robot or not is a completely separate issue.
What applications are there for robotic surgery besides placing screws and rods?
Well, there's different for other fields. There's other things, but for right now, in spine surgery, that's pretty much it. It's not going to help you with just a microdecompression or a microdiscectomy. There's no clinical use for that at this point anyway.
I'm going to try to pronounce this condition properly. Can a laminectomy be performed with robot?
No. So that's pretty much what I was talking about. Robots do not help with laminectomies.
Okay. Who is the best candidate for robotic surgery for spinal stenosis?
With spinal stenosis? Well, for robotic surgery, it would be somebody who needed a spinal decompression for spinal stenosis in the setting of spinal instability or spondylolisthesis where they needed a fusion. And the robot can help with that fusion and placing screws.
If you've had an open surgery fusion at one level, can you have MIS to address problems at another vertebral level?
I'm sorry, what's the question?
Let's see. If you've had open surgery fusion at one level, can
you do minimally invasive spine surgery at another level? Sure.
Is spinal fusion done entirely from the back of the spine?
No, absolutely not. We do it in the front. We used to do it much more commonly in the front, but due to the less invasive techniques we've developed with posterior spinal fusions, we don't use the anterior approaches as much anymore because they tend to be more invasive.
Is it true that once the lower spine is fused, eventually height discs need to be fused?
No. It's true that some of them will, sometimes, but not every person that gets a fusion gets another fusion, right? So if that were the case all the time, everybody that got a fusion would get another fusion until all their levels were fused, which the vast majority of people that get fusions do not get more fusions. Some of them do. Whether that's a result of increased wear and tear at the adjacent level because of the fusion or not, that's a controversial subject, which we could talk about all day long. But some people that get fusions do end up with more fusions. Not everybody. Most people don't.
How long do fusions tend to last? Do they last a lifetime? Is it common that after some years you need to go in and fix
Assuming the
things?
fusion heals correctly, it's permanent. So it's the other levels you need to worry about. Yeah, so, wearing out more levels, that's the concern.
Okay. A guest says, I have spinal stenosis, which manifests itself by numbing of the front thigh muscle if I stand in one place for too long. Can MIS help?
Well, that's most likely, yeah. I would have to see the films and examine the patient to determine that definitively, but yeah, most likely.
Can robotic surgery be used to fuse L3 through 5?
Definitely.
Yes. The question here, how would this surgery alleviate pain for degenerative disc disease?
How would this surgery
How would
alleviate pain from herniated discs?
Yeah, from degenerative disc disease.
From degenerative disc disease? Well, again, if you have a herniated disc that all you need is a microdiscectomy, the robot's not going to help with that. If you have some instability or a fracture associated with that or something that requires stabilization, then the robot could potentially help.
Does a patient generally have freedom of movement after L4, L5, TLIF?
Well, that level is fused, so there's not freedom of movement at that level, but there's freedom of movement at the other levels. It's a relatively negligible loss of motion, so there's not really anything. An L4-5 fusion is not going to keep somebody from doing anything. You could still go and play professional football if you can get on the Broncos. You can play.
When you do a fusion, what is that disc replacement material made of?
Oh, there's a variety of different things. The most common is called PEEK, P-E-E-K, which is polyethylene ether ketone, which is really just a fancy name for very expensive plastic. But there's also titanium, there's also PEEK coated with titanium, and there's other various instruments or materials that are used.
For the pins and rods, are they typically
Well, the pins and rods are to hold everything in place. The things you put in the inner body space, that's to elevate the height. Typically, degenerative disc disease is associated with collapsing of the disc space. That's a big reason why we all get shorter as we get older. And then what we do is we'll put the screws in and jack that disc space open, make you taller again, put the thing in the inner body, whatever we're using, and then lock it into place.
Do you ever see patients with any sort of allergic reaction to any of the components that you use in this process of fusion?
So back when I trained, we used to use steel, and patients had a lot of reactions to steel, but we use titanium alloys now, and it's much less common. I can't even remember the last time I had a patient react to an implant. I mean, it happens, but it's incredibly rare. For me, it's less than 1 in 1,000.
How long is the hospital stay after a TLIF?
Well, the way I do them, minimally invasive, sometimes patients go home the same day. Usually we just watch overnight. It's called a 23-hour observation. We don't even admit the patient, and they go home the next morning. That's the most typical for one level. But the more levels you do, the longer you're going to stay.
And so how long typically is the recovery process? Does it depend on what set of discs you've had fused, or
It
yeah,
depends on a whole variety of things. How big of the surgery? A big factor is how, what does the patient look like going into surgery? If the patient is completely decompensated and comes in a wheelchair and waits that long to have surgery, there's only so much you can do. You can fix the problem, but it's going to take them an enormous amount of time to recover. If the patient's more healthy and fit, they will recover a lot faster. So, it has a lot to do with the patient, almost more so than the surgery.
We have a guest who asked, how many robotic surgeries have you performed that were not successful, meaning they did not relieve pain in the patient's spine?
Oh. I would have to go back and call all my patients to really know for sure, but I honestly can't think of one off the top of my head that failed to do anything. So that's kind of a bad question, because everything is not black or white. When it comes to surgery, it's not they either get better or they don't. It really doesn't. It's more of a how much did they get better is more typical. So if patients have realistic expectations going into surgery, if you're 80 years old and you have horrible back pain, you come into surgery, I'm not going to make you any younger. So, if you have expectations to come out and feel like you're 50, you're going to be disappointed. But if you have expectations to come out, relieve your horrible back pain, but you're still going to be 80 years old, you're still going to have some back issues now and again, then you're going to be happier. And, a lot of outcomes have to do with expectations going into surgery. So if patients have unrealistic expectations, they're generally not going to be happy. Most of my patients are happy, but that's because I tell them the truth going into surgery.
A guest mentions that a recent New York Times article seemed to say that the vast majority of back issues should be dealt with non-surgically. So I'm sure you go through a series of treatments before surgery is recommended. So
Right.
can you speak a little bit about that?
Yeah, so I talked about that in the talk. The whole initial part of the talk was non-surgical treatments. And so let me just give you a little statistic. I only operate on about 10% of people that walk into my office. So 90% of the people that make it to my office anyway, a neurosurgeon's office, do not get operated on. So that tells you right there, the vast majority of people get better without surgery. And that's, all the things I talked about, anti-inflammatories, muscle relaxants, ice, physical therapy, sometimes maybe steroid shots, nerve pain medicine. Very rarely do I use narcotics, almost never. But there's a whole variety of different things, and most people don't need surgery.
A guest asks, I had a C1 and C2 fusion 20 years ago. I think you've addressed this already, but I'm going to ask this question. Had a C1, C2 fusion 20 years ago, and the vertebrae right below it are now disintegrating. Can these be fused and fixed robotically?
Absolutely.
Perfect. Can MIS be used for a facectomy?
For what?
I'm going to spell it. Facete.
Oh, facetectomy?
Yeah.
Well, a facetectomy is of decompression, so the robot does not help with that. But usually if you're doing a facetectomy, you have to stabilize the spine, so a robot can help with the stabilizing part of the surgery.
We have come to the end of our questions that have been submitted so far. So we're going to allow a couple of more minutes for some more questions to come in. I wonder, I was going to ask you a question, and now, How long would a person need, what is your scheduling like at this time? And do you need a referral before someone calls Boulder Neurologic and Spine do you need a referral before you can seek treatment at your practice?
We don't require referrals, so patients can call up and make appointments, but usually it's good to touch base with your primary care physician and see if you actually have a problem that's appropriate for a neurosurgeon to see, because I'll just be honest with you, the neurosurgeons charge more than primary care doctors. So if you don't have a neurosurgical problem and you come in and we charge you 3 times as much as a primary care physician to tell you you don't have a surgical problem, you're probably better off starting out with your primary care physician. But we're happy to see you, and pretty much all of our surgeons at Boulder Neurosurgical Associates use robotic spine surgery. So, you know, if patients can't get in to see me in a timely fashion, then, you know, you can make an appointment with another one of ours. And you can also call up and ask our people. We actually have human beings that answer the phone. We don't have mazes of recordings on when you call our office. But you can ask them to ask us if you have basic questions, so you don't necessarily have to make an appointment to ask a question. You can ask our staff, and they can pass it on to us. So if you have an appropriate condition for us to see you with.
What if you can't get an MRI?
Well, it depends on your condition. Sometimes we'll do a myelogram. Sometimes we use a CT scan. Just depends.
This guest had an aneurysm repair.
A cranial aneurysm? Well, that...
Didn't say. Just
Yeah.
says, what if you can't have an MRI, parenthesis, aneurysm repair?
Yeah, that's... so this has nothing to do with robotic spine surgery, but this is a totally different topic. But, you know, I would say consult a vascular neurosurgeon for that issue.
Okay, there was one here, let's see. I'm sorry, we're having a little, yes. I have a question, says a viewer. A pinched nerve between my L4 and L5, which causes testicular pain. Can this surgery help?
Well, we would have to get to the bottom of why you're having testicular pain. If you need instrumentation, then the robot can help with that. If you just needed a decompression, then you would not need the robot. The robot wouldn't add anything to the surgery.
This guest asks, how well or how low could I be expected to bend with an L3 to L5 fusion?
Almost as low as you normally do. Yeah.
We have time for a couple more. How effective are steroid injections?
Well, it depends on the condition. For appropriate conditions, they can be very effective, but they usually become less effective over prolonged periods of time.
Please explain a decompression.
Well, typically you'll go in, minimally invasive, you make a small incision, and it's kind of like a roto-rooter. It's kind of like when your drain is plugged up and you go in and you roto-root that out. So you kind of sneak in there with a microscope and you drill out with a high-speed drill that revolves at 60,000 revolutions per minute, and you clean out that around the nerve roots. So don't try that at home.
All right. Can chiropractic treatment, in your opinion, help with lower back pain?
I'm sorry?
Can chiropractic treatment help with lower back pain?
Absolutely. There's a lot of chiropractors out there that do very good work. And for patients that don't have surgical issues, I refer them to chiropractors all the time.
Is MIS just making a smaller incision for the same spinal fusion as no robot?
Pretty much, yeah. You do the same thing, but through smaller incisions and less dissection.
What is the difference between a neurosurgeon and an orthopedic surgeon?
Orthopedic surgeon does an orthopedic residency. They treat hips and knees and hands and elbows and most of their residency, and then they usually do a 6-month rotation in spine. And then when they finish that residency, they go and do a fellowship on spine, specifically spine, for a year or 2, and then they become a spine surgeon. Neurosurgeons basically spend their entire residency treating only brain and spines. And so all neurosurgeons, when they finish their residency, they can be practicing spine surgeons. Some of them go on to do specialty fellowships, just to get added training. That's the difference.
All right. I see. Well, we're going to check. All right. All right. I'm sorry. We have a question. Okay. I have a pinched nerve at. Okay. Let me get back to it. I have a pinched nerve at L5 and S1 and and scoliosis at L3 and L4. Would you recommend robotic fusion on L5 and S1?
Well, that's kind of like asking your mechanic if he recommends a new carburetor on your car, but he hasn't actually looked at your car yet. I would have to see the films, examine the patient, and determine what was appropriate. If you have an appropriate surgery for that, absolutely, I would recommend it. An appropriate condition that would improve with that surgery, I would recommend it.
All right. Okay, one more, please. Let's see. Oh, does arthritis affect the fusion process?
Well, arthritis is typically the underlying condition that ends up causing the problems that results in the need for the fusion. So once it's fused, there's no arthritis. You eliminate the joint. If there's no joint, there's no arthritis.
Yeah. All right then. Well, Dr. V, thank you so much for your time and expertise tonight. I apologize that we need to close early tonight, but again, there's an unforeseen scheduling conflict that we will have to address questions at another time. Do feel free to submit your questions as you've been directed in your chat box. And a recording of tonight's lecture is available at bch.org/livestream. You'll also receive a post-lecture survey by mail. Please take a minute to fill this out. And again, please visit bch.org for information on the COVID-19 vaccine. Thank you for joining us tonight, and have a good night. And we'll see you next time. Thanks so much.
Thank you.